We're going to talk a little bit about C-spine, and for those of you, how many work primarily in a fast track or a rapid sort of assessment area? So a lot. And certainly when I've worked in those areas as a physician, the thing that happens is what goes to fast track depends a lot on what's happening in the main ED. As soon as the main ED is really busy and slammed, suddenly you find patients on gurneys and seat collars lined up for the fast track. You're like, yo, things like, you're working in the fast track and it's a guy with one eyeball with HIV and a headache, and the fast track note says headache. Okay, sort of. But anyway, so to be clear, we're not really focusing here on, the more serious, you got a spinal injury, multi-trauma. We're going to talk about other things, but C-spine clearance, from what I just saw in the audience, definitely belongs in here, and so we're going to touch on it. We're going to look a lot more at minor than the severe, as I said. So minor trauma stuff and minor neck complaints are really common. They do often end up in fast track, and then you find yourself there wondering whether you should really go the full distance for CT imaging or whether plain films are indicated, and we're going to talk about that. And then there's a lot of other sort of neck, shoulder, arm complaints that end up in those settings that we're going to address too. So we know that when patients are in a collar, just leaving someone in a collar, we did it in our hospital in a study we published with volunteers, aka residents, and we found that if you take healthy young residents, put them on a backboard and a collar for 2 hours, about a third of them will be symptomatic for a couple of days afterwards. So you would like to get people off the backboard and out of the collar when you can, and sometimes this ends up, as I just indicated, as being sort of a fast track responsibility, and so we're going to go through that. Now, how many of you are doing this, clearing some C-spines here and there? So quite a few. So we're going to go through it. We're going to look at both the Canadian rules and the Nexus rules. I think they're both acceptable. I know a lot of people who sort of have merged them in their own mind. They sort of do the Nexus rules, but if there's a really bad mechanism, then they divert to imaging. And mechanism isn't in the Nexus rules, it's in the Canadian rules. So they're sort of merging. No one has looked at this merged thing to see if it works, but presumably Nexus alone works. So there you go. So here's Nexus, the 5 things that you're looking for. Does the patient have midline cervical tenderness? If they don't, and a lot of people with minor MVAs have paraspinous tenderness, not midline. If they aren't drunk or intoxicated, this is one of the most common reasons not to be able to clear people. If they're drunk or if they've been drinking, you shouldn't clear them. We know from the old San Diego trauma registry paper, when they looked in their series, it was a huge series, like 40,000 patients. In that series, there were 36 missed broken necks. Obviously, missing a broken neck is not part of the part of the group you want to be in. Of the missed broken necks, it was relatively informative to look at why they were missed. So a third of those missed broken necks were because someone thought they could clear someone who was drunk or intoxicated. So if you want to clear people who've had a few drinks, you're asking to be in that side. Normal level of alertness, in other words, they got to kind of know what happened and where they are and what's going on. They can't have a focal neurologic deficit. That's pretty obvious. If they can't move their legs, you're not going to clear them. If they've got priapism holding up the sheet, you're not going to clear them. And then they can't have painful or distracting injuries. Now, that wasn't defined. None of these things were in the study, which is one of the strengths, but you have to decide, is a fractured toe a distracting injury? Maybe not. Is a tib-fib fracture a distracting injury? Probably it is. We sort of generally use, although this was not stated in the study, if people have long bone fractures, we consider that to be a distracting injury at our institution. Anyway, if the answer is that they have none of these things, then they don't need x-rays. They can be cleared from the collar without a functional test. You don't need to move them or anything. They're done. If they can't be cleared, then you need to x-ray them. And many places have just said, we're going to CT all of these because CT is better. I actually personally think that's probably wrong. It leads to a lot of usage of CT. There's no question CT is superior to plain films. No question. The question is, what's the pretest probability of a broken neck and someone with a really minor mechanism? Maybe it's a ground level fall or something like that. I think that that's probably a place where plain film still could be used. They're a pain in the ass to do. You got to get the pull on the arms to get the C7 T1 interface, etc. So the fine print of Nexus is here. I'm not going to detail it, but if you don't, what I will say about it is for your practice, it's worth looking at it, because if you don't do it correctly, you're asking to be on the missed side, which you don't want to be on. And here's the Canadian C-spine rule. If you're going to use this, and I think the Canadian C-spine rule is fine. I don't have a strong issue with whether you use one or the other. The Canadian C-spine rule, though, as you can see here, is a much more complicated algorithm. You really have to have it posted if you're going to follow it, or on an app if you're going to follow it. The big difference is that it's got some mechanisms of injury that are worrisome. So you see the dangerous mechanism box on the right? A lot of people have merged that box with the Nexus rules. And this just shows who uses them. Not surprisingly, the Canadians use the Canadian rules and the Americans use the Nexus rules. There you go. I put this algorithm in here just to look at, and the reason I put it in here is because it still has a role for plain films, and I've already sort of touched on that. If the pretest probability is really low, but they've had a couple of beers, or they just keep saying they have midline tenderness, it might be appropriate to go to plain films first. And there's another deal. So in terms of this dilemma, there's no question that CT is a superior imaging study. The question is the cost and the radiation and how much time it takes to do them. And so there's an issue with that. And so we sort of have to decide. Right now, I would say that in general, many institutions have said they're not going to get plain films on these at all. That's either CT or nothing. On an intellectual basis and with what I know of the research, I think that conclusion is not quite validated. It is, by the way, what ATLS says in the newest edition as well, no plain films. So the younger the patient, the greater the risk of future cancer. So if you're seeing young people that were in accidents, remember the incidence of C-spine fractures in children goes way down. They have much more mobile, ligamentously free-moving necks, so they don't break as often. And so again, your pretest probability is going lower and lower. The main cancer issue with this imaging is thyroid cancer. It's not scatter now that we're talking. When you're doing a CT of the neck with 5-millimeter cuts, you're talking about a direct hit to thyroid. Thyroid cancer is, a pretty serious issue, and the rate of thyroid cancer has been increasing, probably in part because of this. I did analysis at our institution, doing all the usual things. Here's the radiation dose, here's the pretest probability, all the assumptions, and I multiplied it all out. And we would cause 2 or 3 cases of thyroid cancer for every cervical fracture found if we x-rayed, CT'd all of our low-risk pediatric trauma patients. I don't think that's a particularly good payback. And that, when you do those kinds of mathematical analyses, you reach the inescapable conclusion that plain films probably should not be dead. High-risk patient, by all means, I'm CTing them. Multi-system trauma, bad mechanism, not clearable, going to get a head CT and other CT imaging. I'm going to get a CT head and a C-spine. But in a low-risk patient with really minor mechanism who's not clearable by Nexus, who finds themselves in a fast-track setting because it's a ground-level fall or a minor rear-end accident, who's not clearable because they had a few drinks or for midline tenderness, I think plain films are totally rational in that setting. On plain films, you want to be looking for the alignment, and you see the anterior contour line here. That's where the anterior longitudinal ligament is. You see the posterior line. That's where the posterior longitudinal ligament is. You see the spinolaminar line drawn in the far back of this. That's posterior alignment. There's a fourth line that you can look at, which is posterior to the canal, where the back end of the facets are, and that's where ligamentum flavum is. Many people draw this last line on the far left of this in the wrong place. Even in textbooks you'll see that line drawn over the tips of the spinous processes. It cannot be put there because some spinous processes are bifid and therefore short, and so you'd have a step off just because it was a bifid process. That doesn't mean that they're out of alignment. And so you have to make sure you know where the spinolaminar line goes. In this drawing, it's drawn correctly. Here you see the differences with CT. Obviously, you get a lot more detail. You can go right through the facets. With recons, with the reconstructions, you get tremendous amount of information and a lot more detail. And so missing injuries is obviously going to be of lower frequency. The question is radiation and cost. So as I said, not dead and gone yet. Consider them in minor cases. If you are going to get plain films, then you have to do 3 of them, AP lateral nodontoid, and you have to see the C7-T1 interface, which means that if you don't see it on your first set, you either need to get a swimmer's view or you need to try again by pulling down on the arms so that the shoulders are out of the way. If you don't get a complete set, you're going to miss fractures. Again, back to the old San Diego trauma registry with the 36 missed broken necks. 1/3 were missed because they had tried to do someone who was drunk. 1/3 were missed because the C-spine films were inadequate. They didn't have the C7-T1 interface, and there was an injury there. And then the last 1/3 were missed because either they were subtle or because the person didn't recognize what was right in front of them, didn't recognize the anatomy. All right. So when you're looking for trauma-related injuries, you're obviously looking for fractures, but fractures bleed and cause swelling. And the place you're looking for that swelling is in the prevertebral soft tissues. You can see the little black arrows and the blue arrows pointing to it, and the blue arrows tell you how much soft tissue is allowed in a normal outline. So the mnemonic, it's nothing to do with the lungs. The mnemonic is 6 at 2 and 22 at 6. You're allowed 6 millimeters of prevertebral soft tissue in front of C2 and 22 millimeters in front of C6. If it's greater than that, you should worry that there's been some hemorrhage and edema and hematoma there. Now, these numbers only really work in adults. When a kid valsalvas or cries, they can push their whole mediastinum up into their neck. I have some great plain films of a kid before and after sedation, one where the kid has tremendous prevertebral soft tissue swelling because they're crying, and the other when they're calm and it all goes away. So you have to recognize that these numbers, 6 at 2 and 22 at 6, are for use in adults. The atlanto-dens interval, which is the space between the anterior portion of the tip of the dens and the anterior arch of C1, is 3 millimeters in adults and 5 millimeters in peds. That always gets people screwed up. They can't understand why the bigger space is in the smaller people. And that's because as you lay down bone, both of the anterior arch and of the dens, the space gets smaller. So the normal space in kids is bigger than it is in adults. And I already talked about the last point on there. Here's an odontoid view. It's an important view. Remember that in both the elderly and in the young, at both extremes of age, high C-spine fractures are the most common. I always, when I look at house design, I'm always amazed by the way we design houses, right? There's a person who wakes up in bed in a perfectly soft, comfy bed. They're feeling shitty because they have a sudden onset headache, or they have chest pain, they're having an MI, or something. And so what do? They get up in their stocking or their bare feet, and they move to a room that's covered with chrome and porcelain with slippery floors. They should just stay there and vomit on their spouse. They would then take them to the hospital if they stayed in bed. Instead, they move to the bathroom where when they fall, they're going to get a subdural or a C-spine injury or a huge laceration. The bathroom is clearly dangerous, and in elderly people who fall in bathrooms, odontoid fractures are clearly the most common fractures that they get. You would like radiology backup whenever you're looking at plain films or CTs of the neck, because they're complicated. Even for someone like me who's been in a trauma center for 25 years, I look at them all myself, but I like to have the radiologic backup when I can. I want the experts to weigh in. What's shown here is the lateral masses, is the heavy dashed line. And then where the alar ligament is the other dashed line, and you'd like those spaces to be sort of symmetric all around. And then the smaller arrows also show you 2 spaces that ought to be symmetric when you're looking at an open mouth view of the dens. In terms of some reflex stuff, C5, 6 is biceps, C7 is triceps. And these are not pure reflexes. They're drawn here on this drawing as if biceps is purely C5. It's C5, 6. Brachioradialis is C6. Triceps is almost pure C7, but not completely. And that's why sometimes you'll see someone, if someone comes in with their hands up like this in C-spine precautions, and then you put your hands down, And a few minutes later, they reach and adjust the collar, and then this hand is up, and then they say something, and then this hand is up, and they can't put them down again. That tells you what they have. Biceps is in, C6, they can put their arms up, but they can't put them down. So C7 is out. That tells you where the fracture is. That's a bank robber's fracture. Also, I would point out that for C8, remember there's an additional cervical nerve, right? There's 7 vertebrae, but 8 nerves. For C8, there is no reflex. This is 8 fingers doing C8. That's what's happening right there. There's no reflex to check. And here again, you see them coming down. A lot of patients that end up in a fast track have these vague complaints going down their arm. They have chronic neck pain, headaches, and things, and we're going to talk about that in a little bit. So this drawing sets you up to think about that a little bit. All right, whiplash, real common, often a rear-ending injury. The head snaps back and forth. They have ligamentous strains. And if plain films or the CT are negative and they're neuro intact, that's really what you're dealing with. And treatment is a soft collar for 3 to 4 days. We know if you do it for more than that, their neck muscles actually get weak. The collar becomes part of the problem. So I like soft collars just because they're part of my whole philosophy. When someone comes to the emergency room, they all leave with candy-coated popcorn, peanuts, and a prize. They all get something. And so the soft collar is sort of an image that, you know, a symbolism. I don't believe it does all that much, but it's an excellent symbol that I care about them. Plus, they're a strong fashion statement. Everybody wants one. But you should tell them not to use them for more than 3-4 days. They can get NSAIDs, they might need a narcotic. Usually we don't give steroids, but I'll tell you the neurosurgeons, when they see people with persistent pain, almost always do. Seatbelt sign of the neck. So we've learned a lot about seatbelt signs over the years. We know that a seatbelt sign of the belly, a lap band, a lap belt mark, that's fairly serious. If that person has pain, even if their CAT scan is negative, they probably ought to be admitted and observed. Seatbelt sign chest, we've learned not very important. In distinction to the seatbelt sign belly, very important. Seatbelt sign chest, no big deal. They might have a rib fracture, they might have a sternal fracture, but the seatbelt sign to the chest doesn't particularly mean anything. The seatbelt sign of the neck, we still don't really know what to do with. We know that occasionally there are patients with carotid artery dissections, and they might have transient neurologic findings, but we don't know whether they all need to have a CT angiogram looking for this, or how to select them. So what you're looking for is, do they have tenderness over their larynx? If you're worried that they have a larynx fracture or crushed larynx, by all means, they're going to need a CT. Then we have the issues that are shown in this bottom image here. How much bruising and how far anterior does it extend? The more anterior and more dramatic the bruising, the more likely a vascular injury, although we don't have any hard and fast criteria about who need to do this. But I would just say that if you see someone with a great big seatbelt sign of the neck, although there's a lot of resistance when you're in the fast track for sending people back to the main ED, I think this is a reasonable, if you saw that neck down at the bottom, I think that doesn't belong in the fast track. That ought to go back to the main ED. All right, now we're talking about some of these other more chronic things. Every once in a while, someone has a congenital cervical rib, and in the upper image, you see that the patient has one on the left, but not on the right. And this tightens up that circular space, which is their thoracic outlet. And so they get nerve or artery pressure, and they get a heavy arm, tingling, swollen. They might have color changes. And you can do an Adsense test, which is shown down at the bottom here, where you check a pulse, ask them to turn their head and take a deep breath, and sometimes their pulse will go away. I was showing this to residents for years, had never had a positive, and one day I was working and this nurse came down from the ICU and said she'd had all kinds of imaging done and she still had these symptoms. And I did an Adsense test and I was like in shock. I was like, hey, it's positive. And so I repeated her plain films of her neck, and she had bilateral cervical ribs, but because they were symmetric, no one had noticed them. Even though she'd been imaged multiple times before, no one had acknowledged that, hey, that first rib is coming off C7, not T1. And so you'll find them. And these can mimic carpal tunnel and a variety of other complaints. So the EAST test is the elevated arm stress test, where you put their arms up like this and see if they get numbness, tingling, color change. And the Adsense test, which is shown here, is the other test to look at. Now, in terms of thoracic outlet syndrome, this is a fairly detailed image, but it points out that we sometimes think of this as one entity. but they're actually a couple of different entities. There's costoclavicular, there's scalene anticus, and this hyperabduction syndrome, which all give you similar symptoms, but with different movements and activities by the patient. And these will tend to have a positive EAST test, more so than an Adsense. Remember that the EAST test will show you both venous circulation impairment and nerve pinching, whereas the Adsense test only will find arterial compression. And since arterial compression in thoracic outlet is quite rare, less than 1 or 2% of all patients with thoracic outlet have arterial compression, the Adsense test is going to be by far the least useful, whereas the EAST test will be much more frequently helpful. And here they're showing the Adsense test up top and the EAST test down at the bottom. Cervical disc disease is extremely common. We're an aging population in the United States, and you want to do a good neuro exam because you're looking for peripheral nerve entrapment due to these bulging or herniated discs. A thinning disc can also lead to compression of the neuroforamina. Remember, these are not cervical spinal cord problems. These are going to pinch the cervical nerves as they leave, so they're going to have peripheral nerve findings. Eventually, they need surgery. Unfortunately, the surgery is a bear. When they have a compressed or constricted neuroforamina, they can open those up with surgery. The problem is, as I said, the surgery's a bear. It has a long recovery period, and about half the people who get the surgery are no better afterwards than they were before. So they go through all of the expense and headache and trauma of a surgery, and they're not better. And that's why conservative measures, things like rehab, ultrasound, stretching exercises, NSAIDs, all of the conservative measures should be tried and attempted, usually for years before surgery is entertained. Patients have this magical thinking that surgery will cure it, and you need to explain to them that surgery is occasionally the cure, but not always. And some of the patients who get surgery are worse afterwards. All right, cervical spinal stenosis, degenerative changes, usually age greater than 50. Symptoms are progressive. This is a real drag when people have it. A good neuro exam is key. Eventually, it's going to be diagnosed by MRI, which is going to show it. CT will show it too in some cases when it's advanced. And again, symptomatic treatment should go on for months, if not years, before entertaining surgical, neurosurgical intervention. This is something that I find to be very important. You know, we see lots of headaches. We call some of them tension headaches. We call some of them migraine headaches. Occasionally, you're lucky enough to see a true cluster headache, which will get better with oxygen and things like that. But cervical facet syndrome is sort of forgotten, but I think it's really common. If you look for this, you'll find it, and it's quite rewarding. And you can see if you have C23 or C34 pinched in here and you're having this facet syndrome, you're going to have a tension headache that starts right in the back of your head. It's very clear that the C23 and C34 give you posterior headaches that extend down into their neck. And so I think this is worth looking at. Again, some of these respond really well to injection, particularly if the lesser occipital nerve or the greater occipital nerve is involved. Doing a skull base injection with some Marcaine will really make these patients happy because it'll produce dramatic improvement in their symptoms over the short haul, and it'll also reassure them that it's not actually a spinal column problem, it's a peripheral problem. And as I said, C23 occipital neuralgia, looks like it. All right, the stinger. You see a lot of athletes coming into the emergency room. They're playing soccer, they're playing football, they're playing hockey, they're riding horses. They're a cheerleader. By the way, the most dangerous sports position in high school now, the flyer. The little girl that they chuck 2 stories in the air and then catch in a basket after she does 2 summies and 3 twists, that's now the most dangerous sports position in high school. More dangerous than any of the football players they're cheering for. And so we need to recognize that sometimes some of the things that you think of, one of the other high injury sports now that we're recognizing in high school, in high schools that have it, ballet. Ballet produces a tremendous amount of musculoskeletal injuries. So sometimes you got to open your mind. There's this tendency to think like a boy and think, oh, it's hockey, it's football. No, there are other sports that you need to think about where significant forces are being applied. But they come in, they say, oh, I had a period of numbness in one arm after I got hit. That's a stinger. And a lot of times the coach is like, shake it off. They'll sit out a period of downs and then go play. That's fine. If they have persistent numbness and tingling that's peripheral, that's okay too. You want to do your usual neuro exam. But as soon as you see a bilateral stinger, the same way you should feel when you see bilateral sciatica, right? Sciatica isn't bilateral. When you see bilateral sciatica, you should be thinking there's a problem with the big nerve in the middle. That's the only way you get things on the both sides. And the same is true of a stinger. And so when you're talking about someone with bilateral stinger symptoms, that really means they need an MRI to look at their spine. Thank you. I'll end there.